As far as mentation, what I want to say, and it's very true, the more cognitive decline we have in individuals, the more poor oral hygiene they have. The reason for that is they require more help for keeping the mouth clean, and because at that point when cognitively, like I showed you the picture, George was one of them, um, or Nancy, when they have cognitive decline, it's very hard, almost impossible for them to be able to do their own brushing, flossing, oral health that we all do on a daily basis. So it becomes even more important for patients with any kind of dementia, for any kind of chronic condition that causes dementia, to be able to focus that, to at least be able to draw some attention to the mouth, either by the family, by the caregiver, if they're in a hospital, by the nurses. There is a huge association between decline, mentation, and poor oral hygiene. So this is a good example of a 100-year-old lady whom I absolutely adored. She was 100 and she just wanted to see her 100th birthday. And she did. She had the 100th birthday. The reason I pulled this out, you can see without, I'm sure if you just look at this picture and look at her mouth, you can see this is not the most perfect mouth, but healthy, sure. She didn't have any cognitive issues, but she couldn't hear and she couldn't walk. And that's why she was in a facility. She had this little broken tooth here, which she was fine with it. She had no problem. She was eating. Her lip line was a little lower. It looked like she was a missing tooth, but there was no missing tooth. Tooth was fractured. She was fine with it. I was fine with it. But she had a little missing tooth here, and she wanted a fixed bridge. She didn't want any removable teeth. At the time when she called me in and she wanted me to do that, she was 96, so she lived with that bridge about 4 years, and she was very happy with it. She was brushing her teeth. I showed her pictures. I recommended electrical brush rather than manual brush because, as you can see, the arthritis, osteoarthritis, and on the fingers, I knew she wasn't going to be comfortable brushing teeth. And even though she's very good and healthy for 100 years old, she still is a 100-year-old woman. She had a little shake, weak hand. Electrical brush would serve her better. So that's what we did. She kept that area clean. She was fine. And we lost her to COVID 2 months after her 100th birthday. But I use this case because it was the best example for cognitive decline being associated with oral health. Versus this lady, she was in nursing home, or actually this picture we took when she was just moved in a hospice care. When they get to hospice care, I don't know why, but there is this mindset among some caregivers that's the dead end. You don't do anything for them and you just put them there, keep them comfortable till they expire, which to a point it's true. However, I think in anybody's mouth, under any care, when there is an ulcer, a gouge, inflamed lesion like that, it hurts. And at any mental condition or physical condition, that pain is felt. She wasn't able to express it, but she was hurting. The reason this woman was hurting so much, and I was called in because she had her hand on her mouth for a couple of days. She was just yelling, wouldn't eat, and that was it. Even for me to be able to pull her lip down to be able to do that, it took a lot of effort. It definitely took me a lot of establishing relationship in a form of trusting, touching her face. I don't know if she remembered me, but I had seen her for past few years before she ended up in hospice care. All it happened was apparently she fractured part of that's a bridge, that's not a tooth. She fractured part of that porcelain, which covered that bridge she had there. And when porcelain fractures, is actually sharper than knife. When natural tooth breaks, the enamel, the structure of a tooth may be sharp. When porcelain fractures, it's sharp. So when that fractured, basically cut into the lower lip, and that had to be long enough because, as you can see, it created this circular keratinized looking tissue, but extremely painful and inflamed. So all I had to do, I couldn't do anything else, but basically all I had to do, I was lightly with not Novocaine, but gel, numb the area, and I just went in there and polished that area. That's it. I just got the sharpness off, and she was fine until, she stayed there. I went as long as she needed to be there. I put a telehealth there only because I do want to mention this, that having a communication or having a oral health professional on your team, on a health team, it can be beneficial because with all this teledentistry and telehealth, if somebody sent me that picture, I didn't have to go there. I would probably see this a long earlier. As soon as she stopped eating, I would say, just take pictures of inside the mouth. Let me see what's going on. Or just like, so these things can happen. The silver lining around COVID was we all overnight became very, a lot. I mean, I talk about myself. I became a lot more digital savvy than I ever was. At least I know how to take intraocular cameras, how to read them, how to transfer them, how to open up an email, open up. But these things can happen, and these things can be a lot more helpful to the elderly, especially the ones in a hospital, in facilities, homebound. They are the ones that need the most. They are suffering from this the most, and you all can help. This is another example of the fact that this lady was, her name, I guess, was Margaret. She had this big fungus infection here. I don't know if you can see right in here, you can actually see the pus a little bit also here. When I opened that crease, she hurt, and it was raw, it was cut, and it was infection there. This condition is called angular colitis. That's actually fungus infection that requires major treatment. When I walked in, the nurse, not the caregiver, was putting Vaseline on that, assuming that was a dryness. She had dry lips, which she did, but she was hurting as it was being rubbed with that whatever they were using. So they, and then in this case is the same issue, the same problem she has bilaterally, except she doesn't have as severe if it's not infected yet. Would it be infected? Of course. Hers was infected, infected because um, she was drooling a lot. um, Parkinson patients can swallow. It affects the, I mean, you all know that better than I do, but the swallowing and becomes an issue. And the fact they constantly drool is not because they have a lot of saliva. In fact, the decrease in saliva, their mouth is dry because they can't swallow anything. Anything that the mouth, the body produces comes out. And so when the area is constantly moist with the mouth bacteria, that's how it ends up with fungus infection. So when you see the conditions, it has to be able to relate the oral impact on that. Or again, just see something unusual. Whomever is on your team that can connect to a oral health specialist, please utilize them. You serve your patients more than you know. This is actually the same person with the external angular colitis, and the reason is when I looked inside the mouth, she had a broken denture that used to be sit on 4 implants. Apparently implants got loose, lack of maintenance. When things move, they fracture. So she had, even though she at some point had teeth up there all along to be able to chew on these lower ones, when this denture broke, part of it from here and the lower denture all the way from here, even though she had this set of teeth and this set of teeth, she had no occlusion. Occlusion is when the ability to chew. So she wasn't chewing, except every time she closed her mouth, something hurt because things are out of line. And I couldn't imagine that there is no dentist needed to be able to open her mouth. This woman was on liquid diet for 2 years because she couldn't chew. And liquid diet did not, she lost so much weight. She had a lot of major malnutrition issues, and it was all related to the fact her teeth hurt and she couldn't chew. This was another man that was just accepted into a facility, I think memory care, I must say. And he had this partial denture, which probably a non-dentist couldn't see if this is a partial denture. By the fact there is this big piece of metal in front of a mouth, that's unusual, right? We can call that, okay, it needs to be examined. What happened was, even his family who brought him to the memory care didn't know he had partial. He was apparently home for a few years. The family took care of him, and then they brought him to the facility. And apparently this partial was never taken out of a mouth. And I don't know if you know, but we always tell people that wear removable prosthesis in the mouth, we tell them you have to remove it at night. You cannot sleep. So if you have a patient, if you check and you know something is moving, they have a removable, they cannot sleep with it. They have to take it out, and it needs to be cleaned and put back in there the next day. First of all, this thing was embedded in a soft tissue. Soft tissue actually had grown over it. I had to numb him from the whole arch from there to there to be able to remove this. He was hurting. And these progs that are supposed to be retention, I don't know if you can see, if you look closely, you can see under every single one of them, there is cavity forms. So this was in there. And this is when I removed it. I removed this thing, cleaned it. It was this lock here that opened this gate, and that was the way they removed it. It's an old style. We don't make those things anymore, but I know what it was. Right at that lock area, if you see it here, it wasn't even locking. It had a separation by basically tartar. I mean, this was a painful case. It was a very painful case. And things usually don't have to get this far if they are maintained. And during assessment, we'll be able to address them. I just wanted everybody to see how that gate opened up.